So I know we're all keen to get started, so I'm very pleased to introduce our first speaker this morning, Dr. Tammy Grubb, who will shortly present Anesthesia and Analgesia, Continuum of Care from Home to Hospital to Home. She's actually going to present two presentations for us today, so we'll be following after that with top 10 CAT-specific tips for building safe and effective anesthesia and analgesia protocols. Dr. Grubb is a graduate of Texas A&M University and a board-certified veterinary anesthesiologist with a strong clinical interest and research focus in pain management. She is an associate clinical professor of anesthesia and analgesia in the College of Veterinary Medicine at Washington State University, a certified acupuncturist, and a member of the board of directors of the International Veterinary Academy of Pain Management. She has a DVM husband and a myriad of pets of numerous species, all of whom participate in training her in fear-free. Dr. Grubb is obsessed with continuing education and sharing knowledge. She has delivered numerous presentations and authored or co-authored a myriad of papers and books, with the Anesthesia and Analgesia for Veterinary Technicians and Nurses soon to arrive. Her favorite achievement is winning the Carl J. Norden Distinguished Teaching Award, which has been awarded to her from students at 2 universities. So without any further ado, please welcome Dr. Grubb. Thank you.
Thank you very much, Nikki. So now I will take a moment to share my screen and get the presentation to you guys. Let's see how we go. Okay. All right, it looks like everyone can see my screen now. And I'm so excited to see the numbers of people that have joined this series of webinars. Look at all you cat lovers, and it's good. You hate pain in cats, so we're so happy to have all of you here. And I thank Dr. Archer for that introduction, and a special thanks to Elanco for allowing us to come together and talk about cats, my favorite topics, pain management and cats. And you can see that I have chosen for my part of the webinars is anesthesia and analgesia, since I'm an anesthetist. Because really a lot of the pain that we cause, of course, is in anesthetized patients. And so I really can't talk about one without the other. So I'm combining anesthesia and acute pain for my two sessions. And as Dr. Archer said, you'll see some overlap. For instance, for mine, we will do a broad overview of anesthesia and acute pain management. And it's probably a review for a lot of you guys, which is great. But we'll do the broad overview, and then we'll take what we reviewed or learned in this presentation into the next presentation. So you'll see some of the slides again, but we'll make it a lot more cat specific. So there's definitely more cat stuff coming. Of course, we need to state our conflict of interest, and I actually consult with any company that I can that makes or sells anesthetic or analgesic products, because I want to be able to really bring the audience all the latest information. And I do consult with Elanco, who is sponsoring these sessions, and 2 Elanco products will be mentioned in the talk, both Onsior and Nosita. These are this, as Dr. Archer said, this originates from the United States, and in the US, both Onsior and Nosita have very unique label claims when it comes to the cat. Nosita is the only local anesthetic that lasts 72 hours, and Onsior is the only product that we have in the US that can be given in multiple dosages to cats. All right, I think many people think of anesthesia like this, like, people say that it is long stretches of boredom interspersed with short bursts of sheer panic. And we want to make sure that we don't have the sheer panic. We want anesthesia to look like that, the picture on the left there, with a patient who's calm and who's stable, and the anesthesia team is calm. That's what we want anesthesia to look like. And of course, the pain is managed. We're here for pain management. So how do we get from the picture on the right to the picture on the left? We need a plan. We need an anesthetic plan. And we will go through a plan together today, but I also want to give you a resource, and that is these AHA anesthesia and monitoring guidelines for dogs and cats. Because when we finish today, I'm sure you will still want to know more. There's never enough time. So you can get this resource and continue making your anesthetic plan. And it doesn't matter what country you are in, these are open access guidelines. Everyone can get these guidelines. If you go to the website aha.org and find the anesthesia and monitoring guidelines, and then go to the download PDF button, and it's all yours. So please think about downloading them. And then there's also more online in this resource center. Okay, so that's your follow-up, maybe your homework after the webinar is done. Let's get back to anesthesia and pain management. And many people think of anesthesia as just the time that the patient is unconscious. But quite frankly, that's only one phase of anesthesia. Anesthesia is four equally important phases. Anesthesia actually starts with the pre-anesthesia time while the patient is still conscious. And then we have induction, and then maintenance, and then finally recovery. And all of these are very important phases. And what you see in each one of those phases is what is the most important, a highlight of what is the most important thing that we're doing in that phase. It's sort of my little miniature checklist. I have a very extensive checklist too, but a little miniature checklist so that I remember for pre-anesthesia, what does that patient need for preparation? What do I need to do with the equipment? Do I need to start monitoring and support? And I would if it's a critical patient. What sedation and analgesia drugs would I use? And then induction, what drugs do I need? Where are my endotracheal tubes? They should be ready to go. And then maintenance, not only thinking about the drugs like the inhalants, but the things that we need to do in that maintenance phase, like monitoring and support and adding extra analgesia. And then finally, recovery is one of the most critical phases of anesthesia that you'll see. And again, pain management comes up. We often need to readdress pain management in that recovery period. So let's go to patient preparation, patient and equipment. We like to think of anesthesia as a continuum that starts at home, then continues in the hospital, and then ends at home. And in fact, we say that anesthesia really isn't defined by just that time that the patient is unconscious. It really is what we call from home, then to the hospital, and then back home again, where that patient needs to be stable and the pain controlled. And the owner is involved in both that pre-anesthesia part and that post-anesthesia part. And this continuum of care is very, very important for not only safe anesthesia, but for effective pain management. This is really critical to have the owners involved. And an overview, let's start with giving anxiolytics at home. And I think probably most people are very familiar with giving or the opportunity to administer anxiolytics at home, like trazodone or gabapentin. And we have some tips to get that trazodone or gabapentin on board early enough that it really has time for efficacy. And so 2 hours really is how long it takes. We started saying 1 hour and then 90 minutes, and now we say probably 2 hours for the drugs to work. And I have gabapentin and trazodone on the slide. Of course, there are others. These for us are just the most common ones we use in my hospital. So that's why I'm sharing those. And we will see in the next lecture why this is so important. Again, a review, I think, but we'll see why in cats it's kind of critical to remember this step. And the sneak preview is that it makes anesthesia safer if the patient is calm, because just think about the dose of sedative and anesthetic drugs that it would take to sedate or anesthetize the patient. Which patient would require a higher dose? The one you see on your screen now or the one you see on your screen now? Right, a higher dose would be the cat on the right. And because the adverse effects of these drugs are primarily dose dependent, we really want to keep that dose low for safe anesthesia. And there's more to it than that. Let's come back to pain management. These are the pain management webinars. what you see on the left is cats with different reasons to be painful. So, oral dental disease, osteoarthritis, just cats that have a pain face. We'll talk more about that. And then you have 2 sessions on that. So we see the kitties on the left that are in pain, and we see the kitties on the right that have some anxiety or like really high level anxiety, the kitty at the bottom. And you might realize, of course, I think everyone realizes that pain can cause anxiety. If we are really painful, we get anxious, right? And same with our patients, and they might even be worse because they don't understand what pain is. We at least understand it. But what you might not realize is that anxiety makes pain worse. So we have this vicious circle of anxiety and pain. And if we have patients that have both, we have to treat both, or else we're not effective with treating either. So we'll come back to that in the next lecture and some cat specific comments. So we're back to our continuum of care. We've had the owner help us out at home. Let's get that kitty into the hospital. And of course, the most important thing that we can do for these cats for both safe anesthesia and pain management is gentle handling, really respecting that cat and having a dedicated nurse that not only knows anesthesia, but knows what to watch for pain and can help us control that pain. Let's get back to our checklist now and talk about preparing that patient for anesthesia. And preparation really is, for the most part, a good physical exam and history, like you see the that's indicated in that upper left-hand corner. Obviously, any laboratory analysis that the kitty needs is also important. So serum chemistry, CBC, urine analysis. Some kitties may also need more advanced monitoring, like I really like to get blood pressure in cats with chronic kidney disease, and then maybe even other advanced diagnostics. I've been meaning to use the word diagnostics the whole time. Advanced diagnostics like imaging. All right, let's look at this chart. You're probably thinking, oh, that's a lot of words, but we're going through it together. This chart is the American Society of Anesthesiologists chart. And I think every one of you has seen a similar chart. It doesn't have to be the same one because these are just examples on this slide. They are examples of what the chart is used for, and that is to link the health status of the animal to the risk for adverse anesthesia events. It's not exactly designed that way, but that's how we use it. And just remember that that status one, the ASA one, that's a healthy patient with no added risk. There's always some to anesthesia. The ASA2 is a patient with low level of disease, so low risk, and then 3, moderate disease, higher risk, moderate risk, and then 4, severe disease, so very high risk, and 5 are the patients that we have to anesthetize them to save their lives. They need a life-saving procedure, and those are at the highest risk, and we try not to anesthetize those. And look at the difference in the risk for death when we compare with dogs to cats. And I know that anesthesia related death is the worst anesthetic complication, but it's also the easiest to measure. And so that's why we're using that as our marker of anesthetic complications. But you can see that even healthy cats have a much higher risk of anesthetic death than healthy dogs. And when we get to the sick cats, they are at really high risk. And in fact, we know that increasing that ASA status from a 1 or a 2 to a 3, or from a 3 to a 4 or a 5, increases the risk of death by 3 to 6 times. And as the anesthetist, I really want to decrease that risk. And we can do that by taking the time to stabilize our patients and decreasing the level, the severity of their disease when it's possible. So stabilization is really, really important. And back to pain management. Pain management is part of stabilization. If they are extremely painful, again, and it takes a higher dose of sedative and anesthetic drugs to get them asleep and to make them stay asleep. So pain control preoperatively is quite important. Once we have the diagnostics, then we decide what that stabilization means. We said pain management already. It also might mean something short term for acute disease, like putting an asthmatic cat into the oxygen cage as we are preparing the equipment for anesthesia. Or it might mean more long term, like sending a cat with hypertrophic cardiomyopathy home on heart supportive drugs like pemibendin. Equipment preparation is also a huge part of anesthetic safety. So look at that little cat there, tiny little cat, and then all the rest of this is equipment. And think about it, when that cat is connected to the breathing system, so it's intubated and connected to the breathing system and connected to the machine, that machine is part of that cat's respiratory system. Just think about it. That cat cannot breathe without breathing through the machine. So appropriate machine maintenance and preparation is just as critical as patient preparation. All right, now let's finally talk about drugs. That's what we think about with sedation, and that's what we think about with pre-anesthesia is sedation and analgesia. But we had all of those other things to do. But now drugs and back to pain management. We want to pre-medicate, first of all, to start the pain process, the analgesic process. We want preemptive analgesia, and I'll come back to that. We also want to utilize the analgesics, especially the opioids, to help us decrease the dose of the inhalant drugs, the induction drugs. And of course, that wouldn't just be analgesics, that would also be sedatives, which can also keep that patient calmer and it's back to safer because the dose is lower. And let me just quickly show you how much of an impact we can have. The top study shows the MAC, the dose of inhalant, right? The sort of what the vaporizer is set at. And in these patients at the top, these are dogs, but it's the same in cats. If they had no pre-medication, the isoflurane dose was approximately 1.2%. If they had either oxymorphone or hydromorphone, you can see we can decrease that inhalant dose to half. That's a huge decrease. And these drugs, these opioids might be country specific, but remember, they're just representative of the full mu opioid agonists. So you could substitute methadone or fentanyl for those drugs. At the bottom, this one's sevoflurane. But what this one is showing us is as we decrease that dose of inhalant, which we just did in that top study, what does that do for blood pressure? So you can see that those dogs had a blood pressure, that a really high sevoflurane dose. Their blood pressure was 66. Just turning down the vaporizer, doing nothing else, no fluid therapy, nothing, increase the blood pressure to 70 and then decreasing more to 83 and then decreasing even more to 92. So that's how big of a difference we can make in the patient's stability if we utilize our analgesic premeds. Now, this next slide is a crazy, crazy explosion of boxes. There you are, lots of boxes. Don't read it. We're going to read it together. I just wanted this crazy slide so you could see, wow, these are just some of the things, some of the adverse effects that pain can cause. This isn't even all of them. So that's why I wanted you just to see how bad pain can be for these patients. And pain causes neuroendocrine and sympathoadrenal changes, also neuroplasticity and peripheral inflammation, and then finally central processing changes. So let's just look at a tiny bit of this. Over here with the neuroendocrine and sympathoadrenal activation, those are the negative health effects for the patient. So, you could just pick out a few there like tachycardia and hypertension. If you go down that left-hand side, you see increased cortisol release, catecholamines, down to immunosuppression, decreased healing, right? And again, that's just part of the negative pain effects. If you go over to the right, that's the central processing changes. So that's the behavior and quality of life changes like fear, anxiety, stress, even aggression in the really painful patients. And then things like anorexia and insomnia. And then right in the middle, what that is showing is peripheral and central sensitization. And what that means to us is that if we don't control pain, pain keeps getting worse, more inflammation, more upregulation of that pain pathway, which is central sensitization. So it just keeps getting worse and worse if we don't control it. So how are we going to control pain? Let's look at the pain pathway, the mammalian pain pathway. And this is a very important part of our discussion because it's knowledge of the pain pathway that helps us to build effective analgesic protocols. So remember that pain starts out in the periphery in the process we call transduction. And for each phase of the pain pathway, the drug class that is in bold is the drug class that's most effective at that part of the pain pathway. So in transduction, it's the anti-inflammatory drugs. Then we have transmission, where the local anesthetics are the most potent drugs in that part of the pain pathway. Modulation is what happens at the spinal cord. Opioids are very potent there, and also in the brain, which is perception. Finally, there is this descending inhibitory limb that we really talk about more with chronic pain. So we won't talk about it much in our sessions, but again, the opioids are the most potent. Now, what do we do with that knowledge of the pain pathway? Well, now we put it into action to make our analgesic protocol. And what we want is a balanced, comprehensive protocol. And that starts, as we've already mentioned, with preemptive analgesia, or some people call it preventive analgesia. It means the drugs we give before we cause pain, because we are more effective at preventing pain than controlling it once it starts. We want some analgesic drugs on board. We also want to utilize multimodal analgesia, so taking drugs with different sites of action in that pain pathway, or different mechanisms of action, or both. And so just remembering back to that previous slide, that tells us we really need those local anesthetics, those anti-inflammatories, along with the opioids. The opioids can't do it alone, can't provide the analgesia alone, because they're not the most potent in every part of the pain pathway. And then finally, we say don't quit until pain quits, meaning that we need to discharge that patient with analgesic drugs to control pain for as long as that pain would impact that patient's quality of life. And so that would be different depending on how invasive that painful procedure is. But we want to make sure that we are continuing to control that pain. So let's go back to our checklist and look at which analgesic drugs we might consider in that protocol. What would we put in our balanced comprehensive analgesic protocol at each step of anesthesia? So we start with anti-inflammatories unless there's some contraindication. And then obviously the opioids and maybe the alpha-2 agonists, they're sedative analgesics. Induction is not when we usually think about analgesia, but we might give a bolus of opioids. The maintenance phase, lots of things we can do in that phase, including local anesthetic blocks and constant rate infusions. Then in recovery, again, NSAIDs, whatever discharge analgesics that patient needs. And sometimes we continue our constant rate infusions into recovery, especially in those really painful procedures. Let's talk about an NSAID that is specific for cats, and that is robenacoxib or Onsior. And anytime we talk about a drug's efficacy, we also need to talk about safety. So you can see a lot of information on the screen there, and you don't have to read it. This is available with the package insert that comes with Onsior, and also on the product page or the website for Elanco for your country. But just a few tips. Of course, we don't administer NSAIDs concurrently with corticosteroids, and that we should tell the owners the adverse effects of these drugs so that they're watching for them and they can stop administering the drug if they see any adverse effects. And also that the drugs aren't tested for all patients. Like, for instance, Onsior hasn't been evaluated for cats that are used for breeding or pregnant or lactating. And there are also some age and size limitations to Onsior. So we encourage always that we know both efficacy and safety of our drugs. Okay, what else does the patient need for pre-anesthesia? Maybe other drugs like antiemetics, antibiotics, antiarrhythmics, whatever the patient needs. Again, if they're a critical patient, we might want to start monitoring before we ever anesthetize that patient. We also want to support oxygen delivery by supporting blood flow and oxygenation. So we might need to start that cat on some IV fluids. We also want to pre-oxygenate, that we'll come back to in just a second. And why are we so focused on oxygenation? Well, I think probably, again, review for everybody. It's because every cell in the body needs oxygen for fuel. And if we don't get that oxygen to those cells, then cells die and then organs die. And then obviously we've created a very large list of adverse effects from that anesthesia. So unfortunately, what do anesthetic drugs? Many of them decrease both cardiovascular and respiratory function. So, one of our main goals as the anesthetist, in addition to providing good pain management, is to support cardiovascular and respiratory function. And I love this silly cartoon. You can see here, this is the heart. The big red thing's the heart. The pink things are the lungs. And the lungs are handing some oxygen to the heart and saying, we got you something. And the heart says, I'm going to share it with everyone. So a very geeky anesthesia cartoon, but I really like that one. So a little bit about pre-oxygenation, just 3 minutes of 100% oxygen really changes the time to desaturation as defined by an SpO2 reading of less than 90%. And in fact, with just 3 minutes of oxygenation, we get 5 minutes before that patient desaturates. And with room air, only 1 minute. So especially if there would be any trouble intubating, we want to make sure we have pre-oxygenation. Let's go to our next phase of anesthesia, which is induction. And any of these drugs on this slide are appropriate for induction in cats, except for, guess which one we don't induce cats with? The inhalant, right? Not our best way, not our safest way for induction. And we will have a lot more on that in the cat specific lecture. We want to dose to effect. The dose is even more important than the specific drugs. So we'll look at dose in the next slide. And we also then want to get that cat intubated, protect that airway. But there is some cat specific information on intubation to talk about in the next session. All right, let's talk about dose. This picture is just to sort of represent the cardiovascular system. When we inject a drug, so in this kitty, we're going to inject it down in the left forelimb, so that IV injection right down here. When we inject the drug here, that drug goes everywhere. That's what this line indicates. Anywhere the cardiovascular system provides blood, that blood goes there. And the blood is carrying some drug, right? We injected some drug, and so that drug is going everywhere that those vessels go. If the patient is sick or if it's geriatric, then the blood flow becomes what we call centralized, and it's actually then changed just to make sure that those central organs are perfused, that oxygen delivery is preferentially going to the central organs. And yes, of course, some goes to the skin and the muscle, but more of it just stays in the middle, which means now it's a smaller amount of blood with the same dose of drug. So the amount that gets to the brain is actually a higher dose, right? Because it's not going everywhere. It's staying central, including the brain. So we have to remember that patients need a lower dose, that if they have compromise or again, geriatric, but we also have to give it slowly because you can see by the diagram that often the cardiac output, the blood flow is decreased, and so it may take longer for that drug to get to the brain. And this does include analgesic drugs that we've administered IV, so give a lower dose and give them time to get to that brain. Okay, finally to the maintenance phase of anesthesia. And I think we all know the drugs that we would use in that phase. So we're not talking about anesthetic drugs like the inhalants, but very exciting, we get to talk about pain management drugs. And one of my absolute favorite drug classes is the local anesthetic drugs. So we have a painful insult, that starburst that's coming in the upper left-hand corner. And that painful impulse is transmitted to the central nervous system primarily in only one way. And that movie is showing the pain impulses to the central nervous system. But the one way that that is sent to the central nervous system is through opening of sodium channels. And we have drugs that block sodium channels, right? That's what the local anesthetics do. They block sodium channels. And so that really greatly decreases the number of painful impulses that are reaching the central nervous system. And that's a huge impact on pain management. This is a very specific and very powerful mechanism that again significantly decreases the overall pain level of the patient. Let's just look at that in a little bit closer detail. So that's transmission in the upper right-hand corner of your slide. So the X indicates the blocking of transmission. So that painful impulse isn't getting from the periphery to the central nervous system and not to the brain. And that's very important. Here we go again, blocking transmission. And that's just showing that it's blocking to the spinal cord. And if it's blocked to the spinal cord, it's blocked to the brain. And that improves anesthetic safety. We can keep the dose of anesthetics lower. We all know how hard it is to keep a patient anesthetized if it's really painful. So this helps keep that dose low. And this again, excuse me, at the bottom is blocking transmission. And that blocks, that's a slice of the spinal cord you're looking at, that blocks input of that pain impulse to the spinal cord. And this is huge because if that impulse doesn't get to the spinal cord, that decreases the chance that central sensitization will occur. And central sensitization is, some people call it wind up or up regulation. It's that amplification of the pain signal so that the patient feels a lot more pain than we expected them to feel from that surgery or that trauma. And we want to prevent that. And local anesthetics play a really big role in that process. And we'll look at some specific CAT local anesthetic blocks in the next lecture. Here's just a list of a lot of different blocks that we could use. And again, more CAT specific in the next discussion. The other thing that we want to talk about is constant rate infusions for analgesia. And that's a list of the drugs that we have available to us for constant rate infusions. And we have some CAT specific tips to talk about. But why constant rate infusions? Why are these so important for analgesia? Lots of reasons. We get a more stable plane of analgesia. So rather than the patient getting painful and then not so painful and painful, not so painful, right? So they're painful, we give a dose of analgesic drug, pain drops. Then they get painful again, dose of analgesic drug, pain drops. This roller coaster is not a good way to control pain. Better to have that steady plane of analgesia, and we're able to do that with CRIs. Also, because we're keeping a steady plane and not having to give a bolus each time, that's actually a lower dose of drug over time, so that improves safety. We can utilize drugs with very unique mechanisms of action like ketamine, easier to control the dose. And actually, if the patient already has a catheter in, which it would for anesthesia, and is already on IV fluids, then this is a very inexpensive way to provide very effective pain management. Along with analgesia, we should talk about monitoring. We've already mentioned it, and we'll talk about it more in the CAT specific lecture, but very critical to stay on top of that patient's vital signs, make sure that negative trends aren't developing, and we focus our monitoring and support on the cardiovascular and respiratory system. As we mentioned, the drugs, most anesthetic drugs cause some depression of those two systems. So we want to make sure we're supporting them. And we also really need to think about body temperature. Hypothermia isn't just, oh, they're cold. Hypothermia actually changes a lot of the enzymatic processes in the body that make the organs function normally. And without those, the normal functioning enzymatic processes, a lot of adverse effects can occur because of pain, like you see on your slide, because of cold. I'm going to come back to pain. A lot of adverse effects can occur because of cold. And being really cold can actually cause discomfort and pain. If you've ever been really cold, you know how uncomfortable that is. So it's back to pain as well. And we'll talk more about this in the next discussion on, I don't have any great ideas to keep the cats warm, but we have a few tips. Okay, finally now, let's get this patient in recovery. And this is one of the most critical phases of anesthesia, and sometimes the most critical phase. Unfortunately, this is not a real poll. This is just for you to think about, so you don't have to click a button. But if I asked you what phase of anesthesia do most unexpected deaths occur in, the answer is recovery. And I know that you already knew that. And we need to talk about why that is a little bit in the next lecture. But if you look at the data that I've been sharing with you, the risk factors for anesthetic death, we'll see more of it. You can see here that in that study, 70%, 47% of the dogs that died in the study, not 47% of the dogs died, but 47% of the dogs that died in the study died in recovery, and 61% of the cats that died in recovery. So obviously we need to do something about recovery, and pain management will again be part of that. So now we have the patient back at home. So our continuum of care continues, and we want to make sure that we provide analgesia for that pet so that we support, it's not only good medicine, but also so we support the human animal bond. Like you can see this kitty here snuggled up with his owner the day after a dental procedure. He's very comfortable, pain-free, gets to spend some time there watching television. So we want to make sure we utilize our analgesic drugs. And one of the best attributes of the analgesic drugs is duration. Potency, of course, but then also duration. It's a lot easier for the owners to give a drug once a day than to have to repeat that drug multiple times a day. So utilizing our NSAIDs, for example, like the Onsior, and remember, we'll talk more about Onsior in the next session, but Onsior has both an injectable and an oral formulation, and together they can be utilized for a total of 3 dosages. So we can use our injectable formulation as our preemptive analgesia, and then our oral formulation to send home for 2 more days, and it's once a day dosing. And then of course, don't forget any other drug that patient might need. I have anxiolytics on the slide, but it could be antibiotics or other support drugs, whatever that patient needs. And be prepared for the next time that patient comes in. Now we should know if there's some underlying pain like osteoarthritis so that we can have that cat treated before it comes in next time, so we can help prevent that anxiety and pain vicious circle. So that is our introduction to anesthesia and acute pain management. The next session will be more cat tips. In the meantime, we actually have some time for questions. We've left enough time. So if I could turn it back over, Dr. Archer, are you doing the questions?
I am indeed, Dr. Grubb. Thank you ever so much for the presentation, and we will now begin answering the questions submitted during the presentation. As a reminder to all attendees, you can still submit questions through the Q&A feature in the Zoom webinar panel at any time, and we'll collect them and put them live to Dr. Grubb. Apologies to attendees, we have had a few sound issues during that presentation. There's just been a few stutters. We are working to try and resolve that, but we hope that it didn't spoil your enjoyment of that presentation. So, Dr. Grubb, I think we've had quite a few questions around the subject of non-steroidal anti-inflammatories and use sort of pre-op versus post-op. You did expand on that, I think, following when the questions came, but some of the themes were basically worries about low blood pressure, and kidney injury if using preoperative NSAIDs. So interested to get your thoughts on that and how you determine which patients to give preoperatively or postoperatively.
That's an excellent question, and I'm glad someone asked that because it's a very common question and a very important question. And we know, as we mentioned, that the NSAIDs, they're more effective if we give them before we cause pain. But you're right, there's the effective side of the drug and the safety side. And I agree, when the patient becomes, or if the patient becomes hypotensive or hypovolemic, the organs like the kidney can do what we call autoperfuse themselves. They vasodilate, and then that kind of allows blood to flow more easily into that organ. So if the vessels are big, that organ like the kidney is going to get more blood because it's easier to flow than if the vessels are small. That vasodilation is actually initiated by prostaglandins, and NSAIDs, of course, are antiprostaglandin. So if you are worried that your patient might get hypotensive or hypovolemic, so maybe it's a very invasive procedure with a lot of blood, then I agree we should give the NSAIDs postoperatively. And if it's a stable, healthy patient, maybe preoperatively. But I also agree that if it makes you very, very nervous to give the NSAIDs preoperatively, especially to a cat, since they already seem to have a higher share of kidney issues than dogs, absolutely give it postoperatively. That's fine. We are still preventing further inflammation, right? Maybe we didn't catch the first inflammation, but we are decreasing it and then preventing more inflammation. So it's not wasted at all. But my biggest piece of advice is please have an injectable formulation of the drug so that you can give the NSAID before that cat wakes up and can swallow. We don't need to wait until it can take a pill. As soon as you're sure it's stable postoperatively, give the injectable. Don't wait until it's too late. And then definitely don't wait to start until like tomorrow when that patient's at home. Start right away as soon as possible. So preemptive, if they are stable and healthy. Postoperatively, if you're expecting they might become hypotensive or hypovolemic, or if that's just your preference, that's okay too.
Okay, thank you. And we're getting a little bit of a flurry of questions coming in. So just on the keeping to the same theme for the moment, if you're giving the NSAIDs postoperatively, do you wait until the temperature is back to normal before giving the NSAID?
I don't. I do not wait for temperature. I know a lot of people do. And I think if you ask 10 anesthesiologists, you'll probably get 9 different answers of when to start the NSAIDs. Maybe not that many. But I want that NSAID to start working. So as long as the blood pressure was normal when we took that patient off of the inhalants, then I don't wait for body temperature because I want to make sure I've got the analgesic drugs on board. It has nothing to do with body temperature to me. I wouldn't want to give more sedatives if the body temperature was still low because it's going to be a longer time probably before it comes up because the patient's sedate. But I don't wait for NSAIDs. I think that we should give them as soon as possible.
Okay, so switching tack to the anxiolytics, when you were discussing the anxiolytics, we received questions for if you're giving them for several days, what would be your dosing recommendations and how often?
Oh, very good. I'm glad somebody's interested in that. My dosing recommendation is usually middle range of the dose. So look at the dosing ranges on the slides, middle range. We don't want to give it too low or it might not work. And we're giving it for several days for a reason. It's a cat that has really high anxiety or stress, or maybe even a fractious cat. So we need it to work. But if we give the high dose, they might get a little bit too sedate. And I don't mind a little bit of sedation on the day of anesthesia, right? They're coming in for anesthesia anyway, but we don't want them sedate. So middle of the range. And then I usually give it 2 to 3 days, dose it 2 to 3 days for 2 to 3 days. Usually twice a day is enough for those patients. If they are really high level stress, then maybe 3 times a day, but for me, usually twice.
Okay, and any new studies about gabapentin given prior to coming to the vets? The safety of it is the particular consideration.
Yes, and we will look at that in the next presentation. You're reading my mind, so we will definitely we will look at gabapentin in cats in the next presentation.
Okay, you may want to save this as well. The next question was, we use gabapentin at our clinic before cats come into the hospital, but do not use trazodone. So what dose would you use? And if the cat is very difficult to handle, can you use them together?
Ew, great questions. Thank you. And yes, Nikki, that's a great idea. I'm going to save that to the next lecture because that slide comes up again as a reminder that we need to do this in cats. And so you'll see the dosages there, and I'll talk about using it together.
Perfect. Your protocol for fasting preoperatively, Dr. Grubb?
I utilize the fasting guidelines in that AHA paper that I showed you. It really 4 to 6 hours. 6 is usually what I choose in healthy adult cats. That's probably enough. This no food after midnight is really likely too long. And we're seeing that in human medicine too, if you've noticed really shorter fasting times than we used to recommend. And now we're taking that into veterinary medicine from human medicine. But the really long fasting times don't necessarily guarantee that that stomach is empty. And it actually may be worse because long fasting times can cause a decreased motility, GI motility, and also can decrease gastric pH. And so if they do vomit and aspirate, that's a lot worse for the lungs. And it can cause anxiety if they don't have any food. So really that 4 to 6 hour window is what we're shooting for in most of our patients.
Okay, thank you. These really are coming very, very fast. We might not get through all of them. I'm trying to group them together. So a few on, I think I've seen on anesthetic risk. How much does the age of a cat increase that anesthetic risk?
Age definitely increases the anesthetic risk, and we'll mention that again in the next presentation. I don't know that there's necessarily a percentage, but definitely there is an increased risk. So we want to make sure that we are anesthetizing geriatric cats, but that we have a nurse dedicated to that cat, and we're doing everything we can to keep those anesthetic drug dosages low and keep that cat warm. So yes, it's an increased risk, but we can work with it. We can anesthetize those geriatric cats.
And along the similar lines, what would be the ASA classification for a healthy but old cat, for example, 11 years or older?
It's kind of a tricky one because technically, if it's a healthy cat, it should still be an ASA 1. But I also use those numbers to keep me on track of which patients I need to make sure I pay the most attention to. So I would probably make it an ASA 2, just to remind me to focus that it's not a normal, that's normal, but that there is a slightly increased risk. So if you're asking me technically, it's a 1. If you're asking me how I use the scale, it's a 2.
Okay, now we've only got a couple of minutes left, so I'll try to squeeze in some, and we'll leave others to potentially take in the next session if we can, or answer by direct communication later. Do you also dispense post-op opioids, e.g. buprenorphine with Onsior, or has the trend moved to NSAIDs and gabapentin?
No, it definitely depends. Great question. Definitely depends on the level of pain and the type of pain. Gabapentin is good for some types of pain, but it's really not good for like acute surgical pain. If there's no underlying chronic pain or pre-existing pain, gabapentin's not really that great. So yes, NSAIDs, opioids, and then I really like, we'll look at it again in the next session. I like using Nocita because it lasts 72 hours, right? So we're technically discharging the cat with Nocita, not for the owner to give, but it's in the cat. So that really helps with that pain control as well. So yes, oral transmucosal buprenorphine sometimes, the NSAIDs, and then hopefully that local block as well.
Okay, last one, and we'll go with a vet tech question. When I discharge patients with going home analgesia, any tips on what to say to clients to really make sure they actually give the medication, as cats are notorious for hiding pain?
Yes, it's such a great question. It's so hard. I don't know if I have too many tips, but certainly, first of all, making it as easy on the owners we can, because part of the reason the owners quit is because it's not easy, as you said. So let's make it sure it's like that once daily dosing if we can, longer duration drugs. And then I really focus on the negative effects of pain and just tell the owner, pain, your cat is not going to show pain. You are not going to know your cat is in pain, but I promise you, as a scientist, I just caused pain. So it definitely will feel pain. And these drugs are important for healing. And it is true, they are important for healing. Good pain control is definitely important for healing, as we looked at. So just trying to emphasize to the owner the impact on that cat's health and welfare and behavior, so that they really see that they've got to try to do this. And then I also try to teach them in the hospital how to do it the easiest way. Anything we could do to make it better for that owner. But it's hard, but really focus on the positive impact of pain relief. That sometimes works with owners.
Great tips. Okay, unfortunately, our time is up for this session, but we're really looking forward to the next one. I think, Dr. Grubb, we're going to probably take a few more minutes just to see whether we can sort out the sound quality with you. So if attendees would like to take a few minutes break as well, we'll be back very shortly.